first and foremost, thank you for having me. And thank you for having me. And it's good to be here. Let me see. Do I have a fence?
You do now.
There we go. Now, you know all of this already, but I want you to think about it in the context of lungs. And lungs have lots of smooth muscle cells, and they do lots of cool and some cool things. And the problem with them is they, at various times, right, they're reprogrammed to do something else. So prenatally they do one thing, postnatally they do another thing, and as you get older, they do something else. And that's the problem a little bit. So, it isn't, you all know this already. So the proteins in smooth muscle, and where are the smooth muscles from our point of view? Smooth muscle from our point of view. There we go. And the smooth muscle from our point of view is vascular, but also a thing called the alveolus, which is at the end, which gives us a lot of trouble from time to time. No. So there's two stages.
This plays a point in right.
Oh, that one. Thank you. Gotcha. Thank you. So there are two stages. So with human development, what the body does is reuse all the time. So it's going to be doing something different at different stages of your life. And you'd be surprised with that. So it reuses parts all the time. So see, in the developmental stage, right, you see what it does. It's important in the migration of cells. And the migration of cells mainly to make stuff. And then they secrete out this thing called secretion matrix. All it is cement. So what they're doing is they're migrating the bricks to the right spot and they're putting down cement. Now, later in life, you see, in a mature cell, all you hear about is contraction. You hear about contraction. So you see two different things going on here. Now, don't worry, I had a good example of this morning. I nearly put it in. So, so what do smooth muscles do? Like they do large airways, blood vessels through lungs, and the formation of the alveoli. Now that's more key than you think. Now let's do the large airways first. Now this is the trachea. And what is it's literally a horseshoe with smooth muscle here. Smooth muscle here. Now, what happens with these? Now see, that's a normal trachea like this. This is, believe it or not, one of our patients. Just I nicked from somewhere else. And this is, you see, what happens is you breathe out, but this is breathing in, it opens up, breathe out, and it collapses. And it collapses because the back is too soft. And the smooth muscle is not contracting. So this is called tracheomalacia. Now it's an unusual cause of tracheomalacia, but it's called tracheomalacia, means just softening. Now it can be really bad. You see how this one's closed off completely and you don't see a wall. Now this is not the worst one I've seen this week. And they can be really collapsed down. So they collapse down in expiration. Really weird. Now, when you think of airways, right now, because it's smooth muscle, it gives you an opportunity that you don't think of normally. Normally, what you and I we go to the doctor and they give you albuterol. And the purpose of the albuterol is to relax the smooth muscle. In this case, you don't want to relax the smooth muscle, you want to tighten it up. And this is why you give it Atrovent or ipratropium. Okay? Now, sometimes albuterol helps. Now, so that's the reason why you do it. You lean towards this every time. Now, so ipratropium comes in ipratropium inhaler, nebulizer, I think called Duonet, which you're all familiar with, which combines albuterol, so gives you sometimes the best of both worlds. However, the trick is this, you see, when your child is sick, right? The problem is you can have this, all this tracheomalacia going on, but you can also be wheezing, like you have an asthma type picture. So sometimes you have to get a combination of this with this, okay? Duonet. And that's the reason why when you're sick, that's what they're doing. If you're in with rhinovirus, all the usual ones we've seen this winter. No. That's the reason why we get virus vaccines. Now, this just looking at smooth muscles makes the alveolus. Now, what is the alveolus? The alveolus is where gas exchanges. It's the balloons at the end of your airway. Okay. Now, there are two stages now, and I'll show you what they look like. There are two stages. So what happens is they start out with balloons and then they develop shelves. Okay. Now, the purpose of making a shelf is to increase the surface area. And it increases surface area not by twofold, but it increases fourfold. So these things are very important to make. And now, how does ACTR2 mutations affect us? Now, this is a similar example. Right? This is a similar, it's actually a one smooth muscle. Now, I just want to show the various stages of development, right? Just the various stages of development. Now, this is more adult mouse. This is Mr. Mouse here. See how they're bigger when it's mutated? And see how the shelves here, see all the shelves. Now, it's not as pretty, I'll give you that. It's not as pretty, but this is more normal, all right? And these are see these cells here? These are the ACTR2 cells coming up. Now, and I'll show you a few things that we get fired. So that's what you see. So it doesn't form shells. Now we've known this for a long time, and When I wrote this paper, believe it or not, I actually wrote it in the parking lot just up the street because I was waiting for my daughter coming out of ice skating way back then. But it's got to be 15 years. I was thinking about it on the way up. Thinking about it. The last time I was in that, when you drive by a place, the last time I was there. And what happens, you see, this is what it looks like. And the smooth muscle gets there and pushes in. It pushes in. See, this smooth muscle gets there and pushes in. And pushes in. See, pushes in. And that's what these guys are seeing. You see? It's pushed in. Pushed in. Now, and that's no. Now this is one of the older papers looking at the effects of what happens in kids when their alveolus is affected this way. Now they get hyperinflation. I'll show you what all of that looks like. They get chronic pneumonitis. I'll show you what that looks like. And they get cystic lung disease. And I'll show you what that looks like. Now you can't see it too well, but see how there's lots of holes. Lots of holes. There's lots of holes. There's lots and lots of holes. And so be careful since I wrote the paper. Now this will be familiar to a few people in the room. As I said, the trach gives it away, right? And the trach was now, believe it or not, see the cysts, see these cysts here, and you see cysts here, cysts here, cysts here. Now, believe it or not, there are areas of hyperinflation and collapse. And why do you get collapse? That doesn't make sense. Why do you get areas of hyperinflation? This bugged us forever. Why do you get areas of hyperinflation and collapse? That makes no sense whatsoever because they're counterintuitive. So what happens is this, you see, so you think I would know this. Now this is what the airway, this is a biopsy from somebody. This is what normal looks like, see? Really extreme version, see? Big, huge. And see, this is tiny, has more shelf life. Now this is an extreme version, And this is, and this is the extreme version, is from the top of the lung. That's where these things are worst. Now, the reason, now what I wanted to show you, I think I put it now. Now what we do, it's been shown that if you give retinoic acid, okay, vitamin A, that you increase the chance of these growing back. Okay? Increase the chance of these growing back. Now, believe it or not, the dose doesn't matter very much. We were all fixated on a dose for a long time. A little is good, but a ton is not better than a little by much. So what you're doing is trying to balance the side effects of retinoic acid versus just giving a little. Okay, giving a little. Now, which call the side effects are headaches. Okay, so as you know, side effects are headaches. So that's the thing you can look out for, headaches. And now, what I didn't tell you is collapse. Because you see these things here, see those cells there occurring in the corner of the septae. These are called type 2 pneumocytes, which give off surfactant. And if you don't have the shells, they don't grow very well. So you have a partial surfactant defect. Now, what is surfactant? Surfactant is literally what's called detergent, like you used to do the dishes with. What it does is it decreases surface tension and causes them to dilate and contract easily. Okay? What causes them to contract easily? Now, what they do is when your lung is coming down, right, they block up the lungs collapsing completely. That's what surfactant does. So say, for example, you're breathing out, right? How do the lungs say, okay, enough breathing out? What happens is the surfactant kicks in and stops them collapsing down. Now, if you have decreased surfactant, they collapse down. And a lot of you become it. So reduce type 2 pneumocytes, reduce that, and this is what you get. Now, there is surfactant. We give it in a newborn period, right? The reason why we give it in a newborn period is premature babies. But the problem with premature babies is they usually weigh a half a kilogram, which is 1 pound. Okay? So you have a 10-kilogram kid coming in, you probably lose all the surfactant in the northeast of the United States. Okay, so that's the problem, straight up. That's the problem straight. And now the reason why we say which call, believe it or not, inhalers have chemical surfactant in them. So when you take a puff from an inhaler, that's how it spreads out. Okay, that's how it spreads out. So we like, you see me, but everyone says, well, they don't need an inhaler because they don't have asthma, right? Well, the reason why we give them an inhaler is because it's got chemical surfactant in it, but it also turns on the promoter, which is, just let me tell you, inhaled steroids tell the cells that are there to make more surfactant. So it's good in many ways. Okay. Now we cheat, everyone says to us, well, why do we give 4 puffs as opposed to 2 puffs, which is recommended dose? You say we give 4 puffs of the lower dose, right? And everyone says, why do you give 4 puffs? We should give 2 puffs of the what you call the intermediate dose. It's easier in the families. Well, we know it's easier in the families, but you get 4 puffs will give you 4 times the surfactant dose. So we give the lower dose with the increased number of puffs, give the surfactant dose. Now we found this out by accident. Because we were doing COVID studies when we were doing the middle of COVID. We were trying to prevent all the patients in the hospital coughing COVID all over the place, and stop getting off the air. So I don't remember why, but we had a control group we were giving this. So we were giving a thing called ipratropium atropine here to dry up the secretions. So we thought by giving them drying up the secretions, you cough less of COVID around, right? The airway secretions. And then we had a nice control, which didn't have any ipratropium, but had everything else in the inhaler. We had a blank inhaler. We had stuff in it, right? So we noticed the results were the same. And we said, oh, okay, I guess we know why these things are the same. There's surfactant in the control inhaler. That's how we figured it out. And that's what, so we called up the drug company and says, oh yeah, we've been putting this in them since the 1960s. FDA knows about this, but whoever reads the very, very fine print of inhalers. So that's what we use. Now this one is a big problem. This one's a big problem. Remember I said it's in the lung blood vessels. A number of you have seen me in the room with this problem. The lung blood vessels have smooth muscle cells in them, of which factor 2 is expressed. Now, lung blood vessels have a very unusual function that's not anywhere else. Now, say I have a part of the lung that's not ventilating, there's not enough oxygen going in. Okay? the body somehow senses that that part of the lung is not working well and turns down the oxygen going to that part. See, see this, there's no less air going in here. So it learns to turn down the blood supply going in here. So it's an auto-regulator shift blood to the good parts to the bad parts. Okay? Good, no, bad parts to good parts, to the way back. Don't listen. And now what happens to you? And all of you know this. You get a cold, right? Now, a regular person will get a cold and get a little bit of collapse, right? And the blood will figure out, the body will figure out that, okay, blocked off, give them less blood going to that side. You with your active too, right? The blood flows through that area, and your O2 sat is stuck in the 80s. And some of you, stuck in the 70s, okay? And anything you do takes it forever to flip around. Forever to flip around. And let me show. Now, the other big issue with that is what's called oxygen partially works. Okay, because if it's flushing through here, let's say if it's flushing through here, if it's flushing through here, and you give them more oxygen, it'll help partially. And that's the reason why you give them a ton of oxygen, and it goes from 70 up to 85, and you seem relieved. You know what I mean? You seem relieved, and you don't know whether you're improving yourself or not. So now where do we see it? Viral illnesses, post-op. Okay, and then most of you know it freaks out the surgeons. It completely freaks out the surgeons. Okay, now you see it in flights, but it's becoming less of a problem as most airplanes nowadays have a new climate system, and you fly at atmospheric. Okay, you fly at atmospheric. Okay, so most of the newer planes, and I mean new planes, you're flying at atmospheric pressure. So it's less of a problem, much less of a problem. Now, the other thing we've noticed about this, you see this is worse in infancy, but gets better over time. Now, why do we know this? Because we've seen a lot of problems in infancy, and you've seen a lot of problems as they get less and less as you get older. And less and less you get older. Now, the treatments, now I just wanted to, now this always creates huge problems for us, okay? So whenever you come into the ICU, right, we say, oh my God, you got pulmonary artery hypertension, we've got to relax the blood vessels going into the lungs, okay? Now, the problem is that can be a double-edged sword, because if you relax the blood vessels going in here, right, you relax the blood going through here and through here. So you often end up in the same spot. Okay. However, you don't know until you try it. You don't know until you. Some kids seem to get slightly better, others, it's the urge to say, oh, okay, not doing that again. So you have to learn each child is different. And it doesn't seem to be mutation specific, or it really doesn't seem to be mutation specific. Now, the other thing I wanted to put up here is there has been a huge change in the medications, the sildenafil type medications in the last few years. And because we were always talking about this one here, okay? And we talk about this one here. And the problem with this one here is these are relatively hard to give. However, see these ones over here? These ones actually look really interesting because they prevent long-term remodeling. And and when we talk about they have only been shown, in these lung blood vessels. So this one offers an interesting possibility because
Dr. Kinane, Dr. Kinane, can you read those off? Because I can't see.
The main one is bosantin. Bosantin is the main one there. And that's known as MSMDS. This one's not MSMDS. This is only available in Europe. And macrotentin is very early in development. So these are very interesting models long-term models because they prevent remodeling of blood vessels in the lungs. But whether they could work elsewhere is interesting. It's an interesting possibility. Now, we do, the advantage in pulmonary medicine, we have a disease called primary pulmonary artery hypertension, and we see remodeling of blood vessels all the time. See how this, so there are interesting possibilities in the future, I can tell you. My part is complex and simple at the same time. But it seems to generate most of the calls, as Patty said to me, first of all. So thank you. Thank you for having me. Any question? I know I'm embarrassed.
Do we have any questions for him?
There's no.
I'll ask a question because I seem to always ask a question. Two questions, Dr. Kinane. Number one, we seem to have had very good luck with as soon as the onset of an upper respiratory infection comes on, is adding additional medications for our daughter. I wonder if you can talk a little bit about whether other patients should be looking at, as soon as something comes on, starting something sort of prophylactically or early intervention before they develop more serious complications.
I'll take that. No, that's very individual, I think, because most people, believe it or not, are actually on a lot of medications at the start. So most people are on the ipratropium and the inhaled corticosteroids very, very early on, and they stay on them year round and stay on it because they have pretty significant lung disease. So you find most people are stay on the maintenance, and that keeps them out of trouble most of the time. That keeps them out of trouble. Now, if you're not using them all the time, then yes, that's what you call this time. And particularly if you're milder, you won't be using them all the time. Then you just have to start the corticosteroids and the atropines of this world.
And the second question I have is, some of the patients are on
recording in progress.
Some only periodically. I've noticed most of the ones that need it periodically are on a different type of concentrator than like the concentrators that are on the market that give the pulse dose of that. Can you talk a little bit about pluses and minuses of pulse dose, oxygenation versus the constant supply?
Well, the pulse is, the main purpose of pulse is to decrease the amount of oxygen generation that you need. So main purpose of pulse mainly is to what's called only give oxygen when you're breathing in. That's the main purpose, as opposed to as the others. So if you have a concentrator, right? The concentrator doesn't want to make, he wants to make the minimum amount of oxygen that he can. So from efficiency point of view. Now, and I'll tell you the upsides and downsides of each one. And so that's the pulse. Now, however, if you don't have enough strength to do that, it won't trigger. Pulse won't trigger. So you'll see the little ones that put you on put you on a bottle. Okay. And sometimes when you're asleep, you won't trigger. You won't trigger. It's good, some kids really shallow sleepers. And so basically, younger kids, you tend to put on a bottle. Okay. Now there has been a change in technology. Now the other advantage of pulse, and most of it, when you have the home concentrator, it generates a lot of heat.
Yeah.
And it's a heating system on its own, and it's a huge problem now. And now, if you're giving 5 liters, and it'll heat your house. All of you know that. You have, even in what's called wintertime, you have to put an air conditioner in the room if you're going to 5 liters.
Wasteland has its own conditioner for the
Yep.
concentrator.
Yeah, you all know that problem. Okay, and it's a real problem. And try it in summertime. Oh wow, it's a real problem. So that's the reason why a lot of those concentrators have a pulse mode, because just give it to you. So it's reducing the amount of heat, but so that means it has to generate less oxygen, less heat. Okay, less heat. So those are the main advantages are purely mechanical, to decrease the amount of oxygen generated, decrease the amount of heat and the amount of electricity to do it. So it's efficiency. So when you go in an airplane, right, the battery, the portable, the battery is your limiting factor. So they're saying, you need to use the least amount of electricity to give you the amount of oxygen we need it. So it's purely mechanical. So you'll see a lot of them have been, there has been a little change recently. Some of the new concentrators with batteries out there are much, much better. And what they did was it's a bit of, not it too much, but it's a bit of the Tesla effect. They built, the thing is a whole battery around the, which called, they built a bigger battery that's lighter. It's better. So basically, that's what it is. It's purely now. If you were honestly, if heating, you know, you see somebody in the room who actually knows this very well, and they opted for bottle canisters, big huge canisters, because the heating was such a problem in the summertime. It's such a problem in the summertime. So it can be a real problem. So a lot of these things you have to say, and some of them are huge. And you have a tiny room and you can try and fit them in. So a lot of it is it's part of, so you see people look like me. It's the technical part is how big a room, how annoyed are you with bottles, and how much traveling you're going to do, but how much you can do with the heat. So lots of these are technical and mechanical.
Next question. Billy.
Hi, Dr. Kinane. My daughter has mild obstructive lung disease and severely reduced DLCO.
Yeah.
Is that linked with the smooth muscle changes to reduce the DLCO? And she's on CEREC diet. Would that be the best inhaler, or is there any other ways to improve the DLCO? If there's any.
The DLCO is reduced. All right, I can I have my slides back for a second? I can show you what your problem is, right? Let me go back there. Now, DLCO is let me show you. Now, what DLCO is reduced, right? I just wanted to give you an idea what DLCO is reduced. And the question she asks is a good one. And how you measure the surface area of a lung is the DLCO. Yeah. So you can see with this, with all its shells, has a higher DLCO. Yeah. This, with just big huge holes, has less DLCO. So the basic problem that you're getting to, is how can you grow the shells back so that you can improve your DLCO? And now, two options I have to tell you, because we've seen a few of them. It does get better with time. Okay, it does get better with time. And the other thing that we do give retinoic acid. Remember this week we're giving retinoic acid. We do give vitamin A in low doses. And then you see, and then we do, and remember the inhaled steroid that we talked to you about? The inhaled steroid, now, so what we try to do is the inhaled steroid is good, but high dose oral steroids is bad. Okay, so what we do, you see us balancing things out. You know, we say, okay, a number of you know me pretty well, so you end up saying, how many courses of steroids have we had this year? And so what we're trying to do to give a course of steroids below 6, so it allows these shells to grow. So, so number one, time, retinoic acid, and keep the number of steroid doses down. Yeah, it's a really good question. How old is she? Do you mind if I ask how old?
She'll be 15.
Yeah, that's the. I was just asking
Getting
because
worse, the DLCO.
yeah, it's been low.
Yeah.
Now the other thing and I'll just mark it. The DLCO is corrected based on age and your height. Okay, so you can often see the DLCO will look like it's staying the same, but it's actually growing with them. And so it's growing with them. So it's important and time. And and I can talk to you, I can talk to you. Don't be afraid to send me an email.
Thank you. Sorry, one more question, and
Hmm.
she also has elevated phenol levels. Is that linked with the?
Phenol levels,
Reduce
that's,
the-
phenol levels just means, phenol levels means that she has an asthma type picture as well. Okay, phenol levels, and that's the reason why, remember how we said we give inhaled corticosteroid. I'll just spell it out for you. The usual one we give is fluticasone, 2 puffs twice a day, or Q-bar, 2 puffs twice a day. Don't worry, I don't get any money from them. I wish, but
There's a Zoom question to Dr. Kinane. From Adam Caruso, he said, my son currently requires a half liter of oxygen 24/7.
Mm.
He's been getting ipratropium and fluticasone for the last few months, and now we just started including mucimist and vitamin A. Is there any other suggested treatments that we could provide him that can help his lungs stabilize and improve his O2 saturations? He holds his O2 sats very well if his cannula falls out while sleeping, but when he's awake, he desats into the 80s.
okay. And I think, honestly, that's a good question, but you're doing everything perfect. You're doing everything perfect. The other thing is, if you keep doing everything perfect, it actually improves over time. It improves over time. The answer, most people give up too quickly. You say, don't give up too quickly. Do not have a yes, no. These are sort of, most people, I think these are long-term solutions. Think long-term. Do not think day to day, because you would stop everything if you're doing day to day. And we were doing a lot, and as you know, we were doing a lot of this at Mass General, a lot of, we were learning as we go. We learned to say, okay, we get this a number of years ago now, but we look at this and say, no, we tried this. And then we'd stop it and say, oh, it was working, but we didn't best. We did best. Thank you.
What else do we have out there?
Can I just?
Just to kind of elaborate on Adam's question, when you say long-term, would you say just plan on being on these medications through like early childhood?
Yes, sir. Yeah, and I mean, and let me see, you should be on most of these through, 5, 6 years of age. Maybe I would be aiming at most of these. Look, if you had asthma, most people say it's a big problem. If you had asthma, you'd be on these for 14, 15 years. So, and in much higher doses, definitely much higher doses.
Thank you.
Any other questions? All right, thank you very much.
Thank you.